So, yes, thank you to Dr. Kutcher for presenting. Nick was born in Pittsburgh, USA, went to medical school and completed his pediatric residency at Case Western Reserve University in Cleveland. He then went on to complete his pediatric critical care fellowship at the University of Minnesota in Minneapolis, and then he is here at Sick Kids for his cardiac critical care fellowship. He will be returning to the University of Minnesota for a staff position starting this summer. His academic interests are in multidisciplinary simulation and medical education, for which he's pursuing his master's degree. Outside of medicine, he likes backpacking, cooking, and his fiancée, who he plans to marry as soon as he gets back to the States. So thank you very much for presenting today.
Oh, and thank you, Allison, for putting this all together. This has been really great. I've enjoyed getting to watch all of these. So sharing. Okay, everyone can see my slide?
Yes, we can.
Yeah.
Yes.
Okay, thank you. So again, my name is Nick. I'm the Cardiac Critical Care Fellow here at Sick Kids, and I'm going to be talking about the history of post-operative care in our single ventricle population. This is an abridged talk. It's a lot of contents for 15 minutes, a lot of years to go over. So just going to be focusing on some of the highlights and some of the change in philosophies and care management through the years. So getting started, just going way back in history, single ventricles, first described, documented as early as 1699, with just sort of sporadic characterizations up through then. And then really in 1958, across the pond over in London, Thomas Peacock really sort of gave the first attempt at classifying some of these congenital lesions, specifically single ventricles. And his whole thesis was based off of the timing of when the heart arrested its development, and how that played into single ventricle physiology. Then again in 1901, Maud Abbott, who is a name that I imagine is pretty familiar up here in Canada, published her description of the Holmes heart. This is the original drawing that she provided during this description, and it was a double inlet left ventricle. So the first real close look at a single ventricle heart. And then starting to move into the 50s, we have Maurice Lev first describing hypoplastic left heart syndrome, focusing on the underdevelopment of left-sided cardiac structures. And then a couple of years later, the term hypoplastic left heart syndrome was first used. So this was 1958 by the Dr. Noonan as well as Dr. Nadas. So again, up through the 50s, 60s, a lot of focus on single ventricles was just sort of describing and characterizing. And really in the 70s, a lot of attempts were made to correct or palliate hypoplastic left heart syndrome. A lot of different techniques. I listed a couple of them up here, and you'll recognize all of these as things that have been incorporated one way or another into our surgical correction and palliation even today. So there's a lot of trial and error with these. Unfortunately, it also had a lot of ideas that didn't work. So RV to PA conduits, which are a mainstay for single ventricle correction now. But the first couple of attempts included this series, which had a handful of patients who all died within 11 hours. So obviously not very promising, and it was noted at this time that this lesion is universally fatal with no established surgical management. And I sort of love this quote, not because of what it implies, but by who gave it. And it was Dr. Norwood in 1982. So he went on to sort of prove himself wrong by establishing the Norwood procedure. And again, something that we're all pretty familiar with, and not to get into the surgical aspects of things. But it was interesting, one of his early case reports involved a neonate with hypoplastic left heart syndrome and ended up having an 18-day post-operative period, went home and was well at 6 months, which That was in the 80s. I think if someone came back from a Norwood and only spent 18 days in the hospital, today we would still consider that pretty much a win. However, not all of the results were that good right off the bat. Looking at the University of Michigan in the 80s, they looked at 57 patients and going through the Fontan and transplants phase, an overall 89% mortality rate. So mid 80s, just still starting to get the surgical techniques down, the post-operative care, and really not great results. Kind of fast forwarding to the mid 90s, a little bit more focus on the post-operative care. I apologize for the wall of text here, but there are a couple of things that I wanted to highlight in this review done in 1994 that really just kind of put some focus on where things were and how things were done then. So first, again, dobutamine being one of the major medications used, focusing on at this time more of the inotropy and the chronotropy, which has largely been replaced in a lot of centers by milrinone, but still being used. However, kind of reading through this a little bit more, this is something that's definitely changed. Ventilating all of the patients post-operatively to 100% FiO2, carbon dioxide to at or almost hyperventilation with a little bit of respiratory alkalosis. Again, if there are issues, switching to dopamine. However, just reading through this, this was done as a way to change pulmonary vascular resistance and pulmonary blood flow. So that first paragraph is really kind of focusing on changing the vascular system in the lungs as how to balance QPQS. And everything, again, was still revolving around changing the vascular resistances through both the lungs and the body, but focusing mostly on the lungs. Still having the same saturation goals, and again, keeping patients well sedated with narcotics, again, focusing on that pulmonary vasculature. And this led to some misconceptions at the time that the focus, again, was on PVR, that sudden death and bad results were either due to too much or too little blood flow, depending on how the patient was ventilated. And indeed, ventilation and oxygenation was the largest, if not the primary way to control QPQS, either by adjusting oxygen or adjusting how much carbon dioxide was blown off. And this was all done to balance the QPQS. And at that time, we all are very familiar with the equation on the bottom. However, in the 90s, this was always assumed that cardiac output systemically was adequate, and therefore they simplified a QPQS equation even more, and really just focused on arterial saturation, which we know now is probably oversimplifying things. And indeed, that was started to be looked at in the mid 90s. So this study by Rossi in 94, I thought was really interesting, not to turn this into a journal club, but essentially started measuring mixed venous oxygenations. And so that's the graph all the way over on the left. And they sort of realized that not every patient has a normal mixed venous. We can't be making these assumptions about our QPQS. And most importantly, we can't just look at the oxygen saturation in the arterial bed. And so his quote of measurement of mixed venous oxygenation saturation to be invaluable, looking back on it today when every patient gets multiple mixed venuses throughout their post-stage 1 procedure, you can start to see this come into play. And then again, more research being done just a year later, showing that changing the FiO2 and having patients go into a respiratory alkalosis, and again, that focus on the respiratory management of QPQS didn't really change outcomes. It didn't change hypotension. It didn't change pressor support. So people are starting to think that maybe there's other things that we can be doing. And We finally get to this landmark study by Tweddle and Milwaukee in 1999, where they used phenoxybenzamine as an afterload reducer. And they showed that that would lead to lower SVR, better QPQS, lower arterial venous oxygenation differences, better SVO2s, and ultimately a better physiology. So up until this point, again, a lot of the focus had been on managing the respiratory care of these patients and the PVR and the pulmonary blood flow. And now there's a bit of a shift in thinking towards the systemic blood flow and the systemic vascular resistance. So I showed that first kind of flow diagram where overall mortality was 90%, post-stage 1 was somewhere 70 to 80% in the mid-80s. And then there was this kind of nice update in 2002, which showed that by the mid-90s, overall survival after a stage 1 was approaching 40%. And then by 2001, again, we're approaching 80%. So really just within 10 years, doubling at least the amount of patients who are surviving stage 1 onto stage 2. And so that started to open up new possibilities, and one of those being ECMO. So again, it was noted in a review in 2001 that having a single ventricle was a relative contraindication to being put on ECMO post-operatively. Not a lot of people were doing it. However, more and more case series, just looking at individuals, started to show a 50% survival to discharge. And that was pretty comparable with other congenital heart defects at the time. So it became a more accepted practice putting single ventricles onto ECMO, and included this quote as well, showing that it's a valid treatment option for some patients. And then a little ominously here, hopefully this progress will result in improved outcomes for some patients who otherwise would have been lost. However, we still have a ways to go with this therapy. This is a series of studies looking at single ventricle patients who were on some sort of extracorporeal life support. The one in 2006 actually being done here in sick kids, which shows a pretty consistent survival to discharge, somewhere around 40 to 50%. Obviously, this is complicated by the fact that we're putting sicker patients and more complex patients onto ECMO, but sort of that optimism and hope that we were seeing in the early 2000s hasn't skyrocketed any sort of outcomes similar to what the 90s and early 2000s saw with post-operative care. And of course, all of this is in the context of not just ICU care, but better care in bypass techniques, better surgical techniques, introduction of home monitoring systems. So lots of multidisciplinary work going into this population. So starting in the mid-2000s, it became you just started getting better and better results with single ventricles. It became not only acceptable to have a patient survive, but to look at the actual outcome and the morbidity associated with survival. So this review in 2007, talking about how only 25 years ago, so really within just one lifetime of practice, the diagnosis of hypoplastic left heart syndrome went from something that was certain mortality to something that we could reasonably expect to survive to discharge in over half the patients at least. So just surviving was not the goal. And I always sort of hate referring to these PubMed histograms for studies, but I thought this one was really interesting in that there was lots and lots of research being done in the 90s and early 2000s about single ventricles, but next to none of it was involving around neurodevelopment. And then all of a sudden you see a big takeoff, a real shift in thinking away from just survival and more towards quality of life neurodevelopment. And that sort of persists even to today. Which in and of itself, again, still has a ways to go. So 2014, this was a nice table showing how for hypoplastic left heart syndrome, outcomes for language and motor scores for development were sort of average at best. And then on the right, just to orient, the blue line is overall control patients, and the dotted red line is the distribution of language and motor scores for single ventricle outcomes. And so again, sort of in that average score at best. So not a ton of improvement in 5 years, but something that is more and more on the forethought of minds. So getting up to 2021 at this point, there's still a lot of things left to learn on these patients, such as what is the ideal afterload reduction, what is the best medication for that, how best to go about doing that, the role of steroids, which we started to question and sort of readdress even here in this institution, as well as a couple of large multi-center studies. Going beyond just the heart and the brain, those are, typically the first two things that we always think about, but how do the liver and the kidneys play into both recovery and long-term outcomes? This is kind of a growing field in the single ventricle population. Antithrombotic regimens, risk stratification for transplant, and then again, continuing to refine and define the role of mechanical circulation in single ventricle populations. So still lots of work to be done. So a big thank you to Dr. Schwartz. He provided a lot of the information as well as a lot of the context for these for my presentation today. So thank you to him. And then if you remember nothing else from my presentation, I just ask that you remember that not all single ventricles need to be corrected. There are certain people out there, certain creatures in the animal world who naturally have single ventricles and seem to do just fine. And so I'll wrap my talk up with that fun fact, and we'll turn it back over to Allison.
Thank you, Nick. That was excellent. I'm not sure if Steve has any comments or anyone from ICU. Any insights, those who've watched this management strategy develop over the years?
Nick described that all very, very well. So thank you, Nick. I think for people who are my vintage, there are a few of us around the Heart Center. The development of the ability to get hypoplastic left heart patients to survive is sort of been the academic driving force of pediatric cardiac care. I think that's starting to change because we've hit the limits of what we can do by finding new ways to sew things together and get better outcomes for these patients. But it's driven a lot of individual and collaborative research, and we've learned a lot. The early centers that did well did the right things, but probably for the wrong reasons, and I think that's been very instructive and as we understand the physiology. So it was well described by Nick, and it's been fascinating to watch it happen in real time over the last 25, 30 years.